All right, we're on chapter 36 for this lecture. Care of patients with pituitary, thyroid, parathyroid, and adrenal disorders. We're going to start with pituitary, and we're going to start on slide 6. Hopefully this will keep working because I'm still with no power. So we're going to talk about pituitary tumors, and before we talk about pituitary tumors, you actually have to think back to anatomy and physiology. I'm going to try to do this so I can sit down. Anatomy and physiology about what is actually secreted by the pituitary itself. So pituitary, there's the anterior and the posterior. It didn't work. There's the anterior and posterior pituitary. And if you can recall back in anatomy and physiology, the anterior part of the pituitary is actually what secretes a pretty good amount of tropic hormones. And tropic hormones are hormones that actually cause another piece of the endocrine system to work. For instance, thyroid stimulating hormone is produced by the anterior pituitary, the anterior lobe of the pituitary, and that is stimulating, that particular hormone stimulates my thyroid to stimulate its hormones, T3 and T4. Another one, let's see here, another one is follicle stimulating hormone, or FSH, and that stimulates another part of the endocrine system to release hormones. So everything that you see coming out of the anterior lobe of the pituitary actually is a tropic hormone. Again, that means it stimulates another part of the endocrine system to work. Now, the posterior lobe of the pituitary, we see ADH, which is antidiuretic hormone, and we see oxytocin, which helps us have contractions for labor. But we're going to talk about some things that can go wrong with your pituitary. Let me open up my book here. All right, this slide talks about pituitary tumors, and it does say in your book and on the slide that most of these tumors are benign, and that means they're non-cancerous, but that doesn't mean they come without problems. If I have tumors of the pituitary, then it can push in on the pituitary or other parts of the brain. It can cause an excessive amount of certain hormones to be released or an under amount of some other hormones to be released. So there definitely is some problems when it comes to that. It's local symptoms. Local means what's actually happening in the brain. And because of the pressure on the brain, then you're probably going to see some things like visual disturbances, headache, so on and so forth. Your book actually says local symptoms of pituitary adenoma include headache from pressure on the tumor, visual disturbances, probably blindness, personality changes. This is because it's pressing on parts of the brain. Systemic symptoms are things that you see that can affect somewhere else out into your body. So, you know, if it's pressing on a part of your brain, then you may feel fatigued or weak, things like that. Oh, that skips all the way to acromegaly. It does talk about treatment. We'll go back up to pituitary tumors before we go to the next slide. Treatment, it just kind of skips around in there, but treatment, usually treatment is removal of the tumor, and they usually go in through your nose to get that, because remember your pituitary sits right at the base, a little tiny gland that sits at the base of your brain, right behind your eyes. So they'll go in with a long instrument and go in there and do surgery and take it out through your nose. All right, hyperfunction of the pituitary gland. We're going on to the next slide. That's acromegaly. It says excessive secretion of growth hormone, which is GH. Okay, now think about that. If I had too much growth hormone, obviously I'm going to grow big, right? But it's not just tall. It is very large features. And you can see this picture of the lady. When she was young, that she looked pretty normal. And as she progressed, things started to change. And not only did she probably get pretty tall, her head was probably larger, her nose got broader, her hands got really big. So it's not just being tall, and usually the jaw is quite large, and you can usually spot the people who have this giantism problem. And when we have those very large hands or large features, we call that acromegaly. In your book, it talks about giantism. Excessive secretion of the growth hormone results in giantism in children. leading to excessively tall stature because the bone growth plates have not yet closed. In adults, this results in acromegaly. And acromegaly, again, is the big hands and the big features, all right? So all we're saying here is that if for some reason your pituitary starts to secrete large amounts of growth hormone, if you're still growing, if your growth plates have not hardened yet, then you will get very, very tall, very, very large. If something happens in adulthood, then and you've already stopped growing in height because your growth plates have stopped, they have hard hands, the big features, right? Things will start growing. Signs and symptoms. Actually, if we go past that, we see pituitary tumors again. Okay, so let's see here. I don't know why the acromegaly is there, but I suppose we'll come back to it, okay? So keep your mind on acromegaly. The next slide after the picture of the lady with the acromegaly, okay, the large features. Remember, because look there, she was, as a child, she looked normal. So when she stopped growing, things started changing. She started getting those large features. Now on the next slide, we see pituitary tumors again. The diagnosis, this is all the stuff I thought we skipped in the book. Complete history and physical exam. I'm going to do an MRI. MRIs are much better than things like x-rays. X-rays only a picture. MRI, we can look at slices, and with a CAT scan or a CT scan, the same way. I can look inside the brain without actually opening the brain. So I definitely want to involve an MRI and a CAT scan. Remember, we talked a little bit about contrast media today. So if I gave you contrast, then I'll be able to see the features inside you more prominently, as if I didn't put contrast into your body. So I'll get that by IV or injection, and as it goes through my blood system, it will highlight on the CAT scan, and I'll be able to see where vascularity is. Treatment, we talked about the hyposphycectomy, and that's the removal of the pituitary through the nose. Irradiation is just radiation. I can irradiate it, like people who have chemo, they have radiation, and I could do hormone therapy to try to shrink it, to shrink the tumor. Your next slide is a transsphenoidal surgical it's the hyposphycectomy. That's to get the tumor out through the nose. Post-operative nursing care for people who have this. We want to make sure that they're sitting in a semi-Fowler's position. We put them back. It's going to put a lot of pressure on it. Notice any change in vision, mental status, level of consciousness, or strength, because there could have been a problem in surgery. The doctor could have went in too far, cut something he shouldn't have cut. So on and so forth. I want to really watch for diabetes insipidus, because this is about the perfect time that I get this. Now, don't let diabetes insipidus make you think that it's diabetes that we normally talk about, because diabetes insipidus has to do with the amount of fluid that we lose, and we'll talk about that a little bit later. But diabetes insipidus you almost always see in a brain surgery or a brain injury, and that's something to remember. Patient teaching would be in your book on page 837 at the bottom. It says, because nasal packing will be in place for 2 to 3 days, the patient must breathe through the mouth, so they need mouth care. After surgery, it is important that the patient not brush his teeth, cough, sneeze, blow his nose, or bend forward, because these actions may interfere with the healing process. Definitely need to make sure that they know that. All right. Next slide is hypofunction of the pituitary gland. Hypofunction is right past the acromegaly and the hyperfunction. So if I don't produce enough growth hormone, okay, and we're talking about this is on page 838, it says hypofunction of the pituitary gland is a rare disorder characterized by a decrease in the level of one or more of the pituitary hormones. The most common cause of pituitary hypofunction is a tumor, just like hyperfunction. Other causes include autoimmune disorders, infections, destruction of the pituitary. A rare but serious postpartum complication called Sheehan syndrome involves infarction of the gland, and that can also cause a hypofunction. The most common pituitary hormone deficiency involves not enough growth hormone. So if I don't get enough growth hormone, what do you think I'll look like? I'll be very short stature. Bone breakdown is very important. Bone fragility, risk for osteoporosis, decrease in gonadotropins, which may lead to testicular failure. and sterility, ovarian failure, amenorrhea, which is no period, infertility. All these things can happen from a decreased amount of growth hormone. Signs and symptoms of a hypofunction. If it is growth hormone, then we're going to see headaches, visual changes, loss of sense of smell, or seizures. Sorry, I was just reading something in the book here. I was looking up at the top about the reduced growth hormone, but I thought I missed something, but I think we're good. All right, signs and symptoms of a hypofunction of the pituitary that causes pituitary failure. You might see headaches, visual changes, loss of sense of smell, or seizures. The diagnosis is usually the same way as we diagnose the other. It says that we can do a physical exam, we're going to do blood tests, we're going to look at a CAT scan, we're going to look at an MRI. Okay. Treatment. The mainstay of treatment for hypofunction of the pituitary gland is lifelong replacement of that hormone that I'm not getting. So if it's growth hormone, then the person's going to get growth hormone for the rest of their life. Diabetes insipidus. Oh gosh, I started talking all the way through there. So we went through hypofunction. We saw what caused the hypofunction on slide 11. On slide 12, we see how we're going to diagnose it, the same way as we did the hyper with the physical exam. Check the pituitary hormones. I can get that by blood levels and an MRI and CAT scan. Nursing treatment for hypofunction of the pituitary is hormone replacement for the rest of their life. Surgery and radiation if it's has to be a big problem. And then, of course, you're going to have patient teaching for after the surgery and the things they can and cannot do. All right, diabetes insipidus. Remember, this is not your normal diabetes. Diabetes insipidus, and notice it says central diabetes insipidus is associated with brain tumors, head injury, neurosurgery, or the central nervous system infections. It's not anything to do with your pancreas like your other diabetes, what we think of blood sugar problems. This is completely has to do with decreased production of the antidiuretic hormone. Okay, so antidiuretic means that if I gave you a diuretic, it is to make you urinate. If I gave you an antidiuretic, it would mean that you're going to stop peeing. Okay, then you're going to hold it in. Well, diabetes insipidus is giving me decreased production of the antidiuretic hormone, and my body has antidiuretic hormone, so it can regulate how much I actually urinate, because I need that homeostatic mechanism, the proper balance of water and sodium and potassium waste in my body. So in diabetes insipidus, I don't have that. I'm not producing any of that antidiuretic hormone. So all I want to do is pee and pee and pee and pee. Urinate, okay? Urinate. It's very clear. It's constant. It's clear because it doesn't have enough time to sit in the nephrons to collect waste. So when we go urinate, however many hours it is between urinated, you're going to see that it's yellow. It shouldn't be cloudy. Normally it should be yellow and clear, nothing floating in it, but it definitely should be yellow. And the yellow and sometimes the smell, that's the waste that comes out. But people who have diabetes insipidus, they pee so much that the fluid doesn't have enough time to sit in the kidneys and the nephron, and no waste is removed. Now that's going to be very strange, because if I did blood draws on you, and because you were peeing so much, I'm going to see a high amount of waste in a blood draw. So that's something to keep in mind. Nephrogenic diabetes insipidus can be caused by drug therapy or kidney disease. Nephrogenic, nephro means kidneys. So if diabetes insipidus originated in the kidney, which most of the time it does not. Most of the time it's central, okay? When we say central, it's from the brain. But if it's caused by the kidney, it's usually because of some kind of medication. And dyspogenic DI is caused by excessive water intake. And we see that a lot with people in schizophrenia. When I did my mental health rotation, they used to keep the bathrooms locked for people who were schizophrenic. because they would want to drink and drink and drink and drink and cause themselves to have something called water intoxication. So I can see that as dyspogenic DI, or diabetes insipidus. But again, the most common way is from a brain injury or some sort of surgery. Next slide, signs and symptoms are diuresis, large amounts of urine being lost. Remember, I don't have time to pick up the waste, so it's going to be large amounts and probably pretty clear. Thirst, weakness, and fatigue, often from nocturia. I'm tired because I have to get up a million times in the night and pee. And of course, I'm going to be thirsty and weak because I'm constantly trying to dehydrate myself by urinating so much. Deficient fluid volume. I can't keep any fluid in because my body's not giving me any anti-diuretic hormone. So of course I'm not holding enough fluid, and eventually I can go into shock, or I can have central nervous system manifestations because I've got too much waste built up in my body. Normally waste has to go out in my urine, of course, but again, I'm not sitting in the nephrons long enough to collect the waste, so I just have large amounts of clear urine. Diagnosis, of course, I'm going to do a complete history and physical. That's going to be part of my diagnosis for anything. I'm going to look at the urine and plasma osmolality and urine specific gravity. When I look at the urine and plasma osmolality, those two tests help me determine the amount of water and waste in each specimen. So if I looked at a urine osmolality, then I'm going to see a high level of fluid but not much waste. If I look at a plasma osmolality, I'm going to see more waste because my body's not able to rid itself. And then a urine specific gravity. Anytime I talk about specific gravity, it's going to tell me about the amount of waste products per however much urine I put out. And then I can do a water deprivation test. I'll let you read a little bit about that. I'm not horribly familiar with it, but it does talk about it. Well, not really that much. It just says a urine deprivation test. Okay. All right, nursing treatment and nursing management. I'm going to try to replace the fluid and electrolytes, and I have to be careful. If I pump them full of fluid, sometimes it will just get worse and worse. So your doctor will determine, of course, how fast you run your fluids and your electrolytes that could be going into the IV. Hormone therapy. I can give them anti-diuretic hormone. It says in your book, in central DI, remember central's from the brain, a hormone of choice to replace insufficient ADH is desmopressin acetate, available orally, IV, or nasally. Very important for you to remember. Other hormone medication of choices include vasopressin via nasal inhalation or by injection. For fluid replacement, hypertonic saline is used, titrated to match the